Good morning, everyone. Today we are going to discuss Pediatric Urology in our FRCS Part 2 Viva exam preparation series. This is relatively a new topic. We will discuss 3 to 4 scenarios today. Pediatric Urology is quite a vast one. We will certainly do few more videos on that. Anish, floor is yours.
Thank you so much. So we will straight away start with the session. So you are in the pediatric urology table. You are called into the birth suite because you are the on-call consultant, and the concern is regarding a boy with the left testis is not palpable. So how are you going to take it from here?
Okay, so I'll go see this patient myself, take a history, and examine the patient. In my history, I will want to know if there's been any antenatal abnormalities detected. I'll ask about the risk factors for undescended testis. So I'll establish the child's bed weight, if this is a premature delivery, if there's any family history, and if any hypospadias has been noted. I'll then examine this patient, and in my examination, I'll be with a chaperone and with warm hands. I'll be examining to look for, inspect the scrotum for any hypoplasia. I'll check if this is unilateral or bilateral undescended testis. And then with my warm hands, I will palpate the scrotum and the groin, establishing the laterality of this if it's unilateral. I'll try milking down the testicle with my warm hands and try to feel it and see if it stays in the scrotum or if it springs back up. And following on from this, I will then decide on the best management plan moving forward.
All right. What are the risk factors of developing a undescended testis?
So the risk factors include low birth weight, prematurity, neuromuscular problems such as Prune-Belly syndrome, family history of undescended testis, and hypospadias.
Okay. And how many of them will have a positive family history?
About 14%.
Well done. What is the incidence of undescended testis at birth?
So the incidence varies between premature babies and 10 babies. In 10 babies, it's about 3%, going down to 1% at 6 months.
Mhm.
And in pre-10 babies, it's as high as 30%.
Okay. And what is the incidence of bilateral undescended testis?
So this is less common, but I'm not sure exactly what the incidence is.
All right. The EU guidelines gives us a very broad range, but we can say that it could be around ranging from 5 to 30%. So,
Okay.
and so this boy's parents are really worried. So how are you going to counsel them, and what will be your further management plan?
So I'll reassure the parents. Can I just check, is this unilateral or bilateral?
Sorry, this is unilateral. Left
Unilateral,
side.
okay.
He's a term baby,
Okay.
and you haven't noted anything abnormal in the examination, except for the
Thank you.
undescended left testis, which is not palpable.
Okay. So I'll explain to the patients, reassure the parents that majority of the undescended testis will continue to descend up until 3 months of birth.
Mhm.
So I will, in the absence of any other abnormalities, I will arrange to reassess this patient again at 3 months to re-examine and decide if this testicle has descended or not.
Okay, and what if there is no palpable testis at 3 months?
So if it's not palpable testis at 3 months, I would explain my findings to the patient's parents, and in line with the BAPU consensus statements, if a testicle has not descended at 3 months, then it's very unlikely going to descend. So at this point, I will counsel the patient's parents and arrange for examination, arrange to bring them in for examination under anesthesia with a view to progressing to laparoscopy if I don't find a testicle in the groin.
Okay, so what is the consensus statement regarding the timing of orchidopexy?
So BAPU has advised that because of the potential changes to the testicle with regards to fertility, they've advised to arrange or to perform an inguinal orchidopexy at 3 to 6 months. However, this can be it's acceptable for this to happen before the child's first birthday.
Okay, so the parents is asking why this happens, why there is no testis on one side.
So it's the pathophysiology could be as a result of interplay between hormones and abdominal pressure and maybe obstruction to the path of descent. But it's not completely clear why this happens.
Okay. Where does the testis develop from?
So the testis originates from the genital ridge, which lies at the medial portion of the mesonephros.
Okay, and when does it start to descend into the scrotum?
So the descent of a testis happens in 2 phases. The first phase happens at or around 12 weeks in response to anti-Mullerian hormone, bringing the testis from the genital ridge to the deep inguinal ring. Mm-hmm. And then the second descent happens between 25 to 35 weeks, mm-hmm. bringing under the influence of testosterone mm-hmm. and shortening of the gubernaculum, bringing the testicle from the deep ring or the inguinal canal into the scrotum.
Okay, well done. Apart from the anti-Mullerian hormone and the androgen, are you aware of any other factors that are postulated in the testicular descent?
So in the first phase, degeneration of the suspensory ligament mm-hmm. Happens, mm-hmm. and increased abdominal pressure, I think, also okay. contributes to pushing the testicle down to the scrotum.
Okay. Are there any nerve factors or neurotropic factors that help in the descent of testis?
Sorry, say that again.
Are there any neurotropic factors or any nerves that help in the descent of testis?
I think the genitofemoral nerve okay. May be contributory as well.
Yes. So yeah, so it is the genitofemoral nerve, and yeah. It is postulated that it is aided by the calcitonin gene-related peptide (CGRP) released from the genitofemoral nerve that acts on the gubernaculum that helps in the descent of testis.
Okay.
And one of the other things that is considered to be a major influence on the initial descent is insulin-like hormone, INSL3.
Okay, thank you.
I specifically asked this because this was there in one of the exams.
So really? Okay.
During the it might be surprising because we might not think that the embryology will be asked during the viva.
Yeah.
But we have to prepare for the embryology because it can be asked during the viva.
Thank you.
And regarding the what are the nice recommendations for screening of neonates for undescended testis?
I believe that the recommendation advises that as part of the prenatal check, every child should be examined for undescended testis.
Exactly. So NICE says that it needs to be screened, and the first screening should be within the 72 hours of birth. And if there are any concerns, then NICE recommends to repeat the examination at 6 to 8 weeks. And then if there are still concerns, then a re-examination at 4 to 5 months.
Yeah.
So, what percentage of undescended testes are palpable?
So 80% of the undescended testes are palpable and 20 are impalpable.
Okay. And out of the impalpable 20%, which is more common?
So of the impalpable, 40% will be intra-abdominal, 30% will be a blind ending,
Mm-hmm.
vas and testicle up to the deep ring, and the remaining 20% will be blind ending up to the groin, up to the inguinal canal, and 10% may be palpable under general anesthesia.
All right. So you are seeing this child again around 4 months' time. Um, child has gained weight. You examine the left side. You did the milking technique with warm hands, consent chaperone. You still can't find any swelling, any lump on that side. You examine the opposite testis. It is normally descended. The ipsilateral on the left side, the scrotal rugae is not that prominent. Um, it's always it's always important to mention regarding the examination of ectopic locations. So, what is the most common site of ectopic testis?
I'm not sure the commonest sites, but I know that the ectopic sites include the femoral ring,
Mm-hmm.
the base of the penis.
Mm-hmm. Well done. So, yeah, you're right. It could be femoral, base of the penis, perineal, even onto the opposite testis.
Yeah.
And the literature says that the most common site is the superficial inguinal pouch.
Okay.
So that's the importance of examining for the ectopic testis as well. What is a
Yeah.
retractable testis?
So retractable testis is a testis that freely moves up and down, so
Mm-hmm.
up into the inguinal region and down to the scrotum,
Mm-hmm.
and but also one that during the examination, bringing it down requires bringing it down causes no discomfort,
Mm-hmm.
and it stays in the scrotum when it's brought down.
Okay, and I would suggest to add one keyword there, bringing it down to the fundus of scrotum.
Fundus,
And
okay, yeah.
yeah, and what is the recommendation for the treatment for retractile testis?
So the recommendation is because we know that a majority of the retractile testes will eventually settle down in the scrotum.
Mm-hmm.
Recommendation is to keep them under surveillance, and unless it declares itself as an ascending testis, um, in the absence of that, to just continue surveillance until they become adolescents and they can be discharged.
Okay, well done. So you're counseling the parents regarding the further treatment options. So how what are the key factors that you will discuss with them regarding the further proceeding? Because there is no testis palpable on the left side still.
Okay, so I'll explain to the parents that this is an impalpable testis,
Mm-hmm.
and I'll explain that the child requires examination under anesthesia, and as well as to proceed to laparoscopy if the testicle is not palpable under anesthesia. I'll explain that this requires a general anesthesia, and during laparoscopy, the possibility is that the testicle can be found in the abdominal cavity, and if that's the case, if it's very close to the deep ring, I will proceed to an inguinal orchidopexy. If it's a lot deeper than the deep ring, then I will consider performing a two-stage Fowler-Stevens procedure. I'll state to the parents the risks associated with either of this procedure, i.e., inguinal orchidectomy and Fowler-Stevens. So there's risk of damage to the vas, damage to the testicular vessels. So I will counsel them and get them to sign a consent form.
Okay. So will you provide any information leaflet?
Yes, I'll provide them with information leaflet regarding this procedure,
Okay.
as well as information leaflet regarding Undescended Testis.
Will you provide any specific information leaflet?
Um,
I mean,
I'm not sure if it's
there
the
is a
BAUS or the BAPU.
there's a BAUS information leaflet.
Yeah.
So the parents are asking, will you do any scanning or imaging before planning for the surgery?
I'll explain to them that the imaging is not really recommended because it wouldn't change the decision to operate, and most times ultrasound, for instance, will have a false negative rate. So the recommendation is to go straight with examination under anesthesia and plus or minus laparoscopy.
All right. Just to be careful on that one, because when you give the information leaflet, the BAUS information leaflet published in December 2020 says that an MRI scan will be done prior to the procedure, but you can, during the counseling, you can say that that is not the standard, because for an MRI for a child, definitely it needs sedation. So
Yeah.
that's the reason that, and the specificity is more for a diagnostic laparoscopy compared to the MRI scan. You
Okay.
might not need to explain that in the exam, but if that question comes, then you can say that
Yeah.
that's the reason
Okay.
that we are not doing the MRI scan, but going
Okay.
ahead with the diagnostic laparoscopy.
Yeah. Thank you.
Yeah, no worries. What is the risk of testicular atrophy for a inguinal orchidopexy?
2%.
All right. And what's the risk of testicular atrophy for a one-stage Fowler-Stephen?
30%.
Very good. And what about the two-stage?
10%.
Well done. What is the reason that we are doing inguinal or laparoscopic orchidopexy? Why we are not just removing the testis but preserving it and bringing it under to the scrotum?
So the principle of Fowler-Stephen procedure is to divide the testicular vessels and allow the testicle to survive on the artery to the vas. And in a two-stage, this is allowed for about 6 months for the artery to the vas to develop a bit more, and then the testicle is brought down to the scrotum. The benefit of this is to preserve a functionally normal testis for both hormonal and fertility function. So this would be the rationale behind this.
Okay. So what is the risk of malignancy in undescended testis?
So the risk of malignancy ranges from about 3 to 10 times higher risk compared to the normal population.
Okay. And does orchidopexy improves that risk or reduce that risk?
So there is loose evidence to suggest that orchidopexy may slightly reduce the risk of malignant transmission if it's performed early. But this advantage is lost if it's performed late.
Exactly. So that was a systematic review by Walsh in 2007. And the evidence is not that strong, but still it is considered that it might reduce the risk of testicular cancer. Is there any role for medical management in undescended testis?
So this is controversial, and the latest consensus and the guidelines suggest that recommend that there's no role for hormonal therapy in undescended testis.
Okay, so our child, the parents are very convinced with all the explanation. They have agreed to go ahead with a examination under anesthesia with either inguinal orchidopexy or a diagnostic laparoscopy and proceed. You have counseled them, consented them, the WHO checklist is done. And so can you tell me how are you going to proceed from there? The patient is on the table.
Okay, so with the patient anesthetized, WHO checklist performed, sterile prep and drape, I'll examine the child under general anesthesia to feel for palpable testis. If it's palpable, I will proceed with inguinal orchidopexy.
It is palpable now.
Okay, so the steps for inguinal orchidopexy will include making a skin crease groin incision,
Mhm.
and dissecting down to the external oblique aponeurosis, opening this up to identify the testis. Dissection and freeing up of the identification and dissection of the vas deferens and the spermatic vessels, dissecting out and ligation of any patent processes vaginalis. The vas and the testicular vessels are dissected free up to the deep ring to give it some length. The testicle is then brought down to the scrotum. A datus pouch is created, and the testicle is put in the subdatus pouch and closed up. I would also administer some local anesthetic to the child.
Okay, well done. A couple of things that I would, couple of keywords are once as you said, but still to be very precise on saying that you will divide all the cremasteric fibers.
Yeah.
And a patent process vaginalis will be ligated, as you said.
Yeah.
If there is any hydatid of Morgagni, the recommendation is to remove all those appendages.
Yes. Yeah.
And as you said,
Thank you.
mobilize the testis to reach the fundus of the scrotum, keeping in the subdatus pouch. And main thing is that make sure that it is not under tension when it when it lies in the scrotum, in the subdatus pouch.
Yeah.
What is Prentice maneuver?
What's what?
There is a maneuver, or there is a modification that we do during the surgery called as Prentice, Prentiss, Prentice maneuver.
Okay, I don't know what that is. Sorry.
So during the inguinal orchidopexy, if when you try to bring the testis into the scrotum, if it is not possible to bring it down, especially in older boys, you can imagine that the pathway of that path of that cord is like an oblique coming from the deep ring to the inguinal ring. So one thing that you can do is to divide the inferior epigastric vessels and then medialize the cord.
Okay.
So it will be more of like a straight course of the cord.
Okay.
And so that we can transpose the spermatic cord medially, so you can get an additional length to for the inguinal orchidopexy. So that maneuver where we divide the inferior epigastric vessels to gain additional length of the spermatic cord by transposing the spermatic cord medially is called as the Prentice maneuver.
Okay.
So,
thanks.
Yeah, well done, no worries. Regarding the Fowler-Stephen of orchidopexy, you nicely mentioned regarding how it is done and the 6-month stage procedure. What is the survival rate of, or what is the testicular salvage rate of 2-stage Fowler-Stephen?
It's in the order of 90%.
Well done. If nothing is possible, the testis is good. It is lying more than 2 centimeter from the deep inguinal ring. You tried a division of testis first. You planned a 2-stage Fowler-Stephen, but when you go for the second time, you feel that it is very fibrotic and there's no way that we can bring the testis down to the scrotum. Are there any other surgical options that are possible?
So if it becomes fibrotic in 6 months, and you're not able to bring it down,
I mean the testis looks good. It has got good blood supply from the vas deferens and the differential artery. Are there any other surgical options apart from Fowler-Stephens?
So this becomes a difficult decision to make because the benefits of bringing the testis down is one of the benefits is to allow regular examination when the child reaches puberty. So if you're not able to bring it down, then I will recommend an orchidectomy at this point.
There are suggestions in the literature that if the expertise is available and if you can refer to the appropriate site, then microsurgical autotransplantation
Okay.
is an option, and the success rate of that is said to be around 90%.
Okay.
But
So
the
quite
problem is that
successful.
it requires skilled and experienced surgeons, especially in the vascular area.
Okay.
And regarding the orchidectomy, when will you decide what is the indication for orchidectomy in undescended testis?
So the indications include um, an abnormal looking testicle, or if the vessels end in a knobbing, or as I suggested earlier, if one's not able to bring the testicle down
Okay.
because of fibrosis and scarring.
What if the presentation is in the adulthood or post-pubertal period, undescended testis?
So again, if the presentation is post-pubertal, then there is no benefit in bringing the testicle down, and the guidelines recommend an orchidectomy at this point.
Okay, well done. So I think we have completed the undescended testis. I've gone a bit more deeper in this discussion because I thought that would be more helpful. Even if you, I think we have covered almost all possible questions that can be expected in the undescended testis.
Yeah.
Do you have any?
Thank you.
Do you have any questions regarding undescended testis?
No, just the microsurgical technique that you mentioned.
I read
Where did they anastomose it to?
I'm not sure because
Okay.
this was just a mention that in the EAU guidelines and also in the
Okay.
Campbell. So when I was reading, because sometimes if you're doing really well, then this question
They'll
can
push
arise.
you.
Yeah. So, but
Yeah.
I think in that case it will be anastomosed to the inferior epigastric vessels.
Okay. Okay.
So, but still the question is whether there is any length
Options.
of the
Yeah.
testis available. But these are like the questions when you are really pushed and go to the maximum mark.
Okay.
Just yeah. So shall we go to the next scenario?
Yes, please.
Okay. So this is in a completely different setup. You are in the pediatric urology clinic. Your neonatology colleague has called you and requested you to see a 2-week-old infant who is referred for an ultrasound diagnosis of left hydrouteronephrosis. Actually, this was picked up in the ultrasound scan during the 3rd trimester, and the anteroposterior renal pelvic diameter was 5 millimeter during the 3rd trimester.
Okay.
So they thought that they will observe it after birth, and the post-birth scan shows it is persistent. I'll share the screen now.
So I'm using my phone, but I hope I'll see it properly.
Okay. Can you see this?
Okay. Yes, I can. I can see. So this is Grayscale ultrasound scan demonstrating. It doesn't say which side of the kidney, but we know it's the left side.
Yeah, it's LT long, so it is left kidney longitudinal section.
So demonstrating the left significantly hydronephrotic left kidney with dilatation of the proximal ureter, and on the right side there's a scan of ultrasound scan of the bladder, also showing dilated left distal ureter. So this would be in keeping with left hydronephrosis.
Okay, and I'll stop sharing now.
Okay.
So, what are your thoughts now after seeing this ultrasound scan?
So I'm concerned that this child has left hydronephrosis. I'll look at the images of the contralateral side to check that they are normal. I will assess this patient's and get more details about the antenatal scan if available. Given that this child is 2 weeks, is this a male or a female?
It's a male child.
It's a male child, okay. So given that this child is female, my differentials for left hydronephroidrosis would include vesical ureteric reflux, VUJ, obstruction, Megaureter. So I will arrange for this child to have an MCUG and also a microrenogram to help differentiate between obstruction versus VUR.
Okay, so this is a male child, and the anteroposterior renal pelvic diameter is shown as 8 millimeter now.
Okay.
The ureteric diameter, as you can see from that, is very much dilated. It is measured as 9 millimeter.
Yeah.
Are you aware of any hydronephrosis grading system in ultrasound scan?
So there is the grading of mild, moderate, and severe. And I think the measurement is for mild. I think it's 5 to 10, moderate 10 to 15, severe more than 15.
Okay, I mean the most widely accepted one is the Society of Fetal Urology grading system called SFU, which ranges from grade 0 to grade 4.
Okay.
It's mostly subjective. That means that there is no measurements given in that one, and the SFU one, where there is grade 0, there is no, everything is normal. Grade 1, there is slight separation, and grade 2, the renal pelvis is dilated and 1 or 2 calyces are dilated, and grade 3 is renal pelvis dilated and all the calyces are dilated, but the parenchyma is normal, and grade 4 is when the parenchyma is thinned.
Okay, thanks.
So for what is the most common cause of neonatal hydronephrosis?
So the commonest cause, I believe, is the non-specific one, which resolves on its own. And then next to that is PUG obstruction, and then VUR.
Yeah, so the most common, as you said, is transient hydronephrosis. And
a transient one, yeah.
The second most common is PUG obstruction. The percentages varies, but on an average, around 40% of the neonatal hydronephrosis is due to
transients, yeah.
And after PUG obstruction, it is the Megaureter.
Okay.
So, what is a nice recommendation on doing the antenatal scan? So, at what times will you do antenatal ultrasound scan?
Okay, so the recommendations are to do the anomaly scan at 12 weeks. No, the dating scan, sorry, at 12 weeks. And then anomaly scan at 24 weeks, I think.
Yeah, so the initial one to determine the gestational age and to see the number of pregnancies is between 11 and 14.
Okay.
And the anomaly scan is between 18 and 20.
Okay, 18 and 20.
Yeah. And what is considered to be the most sensitive time to evaluate the fetal urinary tract?
I'm not sure.
So it is the 28th week. And
28 weeks.
One of the questions is, what all will you look for in the ultrasound scan at 28th week?
So I'll look for the any evidence of hydronephrosis, hydroureter, and document the bladder thickness. Look for any cysts in the kidney, and also look for the amniotic fluid volume.
Well done. Okay. So will you for this child, they did the ultrasound scan at 2 weeks. Was it acceptable, or should have been done much more earlier?
So 2 weeks is acceptable. We know that scans within the first week of life may not be representative,
Okay.
because the child is usually dehydrated,
Mhm.
and the nephrons may not be functioning properly to produce adequate urine. So this could falsely reassure you that hydronephrosis is settled.
Okay. So you planned MCUG for this child. The
Yes.
MCUG is normal. There is no reflux seen in the MCUG.
Okay.
And you said that you will plan a MAG3 as well.
Yes.
So the MAG3 shows a delayed drainage pattern on the left side. The
Okay.
split function is almost equal. So
Okay.
what are your thoughts now?
So given that there is some drainage, albeit delayed, I will arrange for further follow-up. So I wouldn't intervene at this point, especially with a normal split function. So I'll arrange to see this child again in 6 months' time, with repeat ultrasound scan.
Okay. What's the classification of megaureter?
So Megaureter broadly can be classified as refluxing or non-refluxing. And the non-refluxing ones could be obstructed or unobstructed.
Okay. Is there any name for that classification?
I don't know a name.
Yeah, so it's called as the Smith classification.
Smith, okay.
So initially there is 4 categories for that: the obstructed, the refluxing and obstructed, and the non-refluxing, not obstructed.
Okay.
And then later King subdivided into primary and secondary based on the etiology.
Okay. Yeah.
What is the definition of megaureter?
So by definition, a megaureter is the ureter that measures more than 7 millimeter in diameter.
Well done. And so this child has got a dilated retrovesical portion which is more than 7 millimeter. Normal in the MCUG, there's an obstructed curve in the MAG3. So would you consider the diagnosis of megaureter in this child?
Yes, I will.
Okay. What will be your initial management for this child? You said that you will repeat the scan again to see if it is persisting or if it's getting worse. Apart from the plan for repeat scan, anything else you will do?
So I'm not very clear if prophylactic antibiotic is recommended in megaureter.
What is the BAPU consensus statement in 2014?
For megaureter, I don't know.
Okay, so that is one of the documents that definitely we have to read. It is available as a free PDF. It's the BAPU consensus statement, which was released in 2014. It says that the antibiotic prophylaxis is advisable for the first 6 to 12 months.
Okay.
What is the spontaneous remission rate of primary megaureter?
Spontaneous resolution rate?
Yeah.
I don't know.
It is around 85%. So that's the reason that we can. So straight away surgery is not considered as the best option unless there are impending indications like parenchymal thinness or if the patient is septic, things like that. But otherwise, there is a role for conservative management in primary megaureter.
Okay.
And how we reach a diagnosis is we have to rule out a bladder outlet obstruction and vesico-ureteric reflux with all the investigations you have mentioned, and that's how we reach the diagnosis of megaureter. And the BAPU consensus statement definition of megaureter is the retrovesical ureter diameter more than 7 millimeter from 30 weeks of gestation. Then we can consider the option. The diagnosis of megaureter.
Okay.
So you are following up this patient at 6 months' time. So what will be your indications to go ahead with the surgery or continue with the conservative management?
So if everything is stable, then conservative management will be recommended. However, if the child is having symptoms such as recurrent urinary tract infection, if there's evidence of progression or deterioration in renal function, or a drop in the split function less than 40, then this would be a recommendation. This would be indications to intervene and reimplant the ureter.
Okay. So the consensus is that in an asymptomatic patient, even an initial differential renal function below 40% is an indication. Or,
Okay.
as you said, when you review the patient afterwards with repeat MAG3 scans, if there is a drop of more than 5% on serial scan, that is an indication for surgery. And also
Okay.
increasing dilatation on the further ultrasound scan is also an indication.
Yeah.
For our child at 6 months time, if the repeat MAG3 scan shows that there is a deterioration of differential renal function more than 5%, and you decide on the surgical management, what are your options?
So the options include cystoscopy and ureteric stent insertion. Initially, if this is an obstructed VUJ, you could also try balloon dilatation and stent insertion. And then the definitive option would be ureteric reimplantation on that side.
Okay, so when will you do ureteric reimplantation? Will you do it at 6 months time?
So the ureteric reimplantation is it needs to be balanced with the child, with the size of the child. And so I wouldn't do it at 6 months time. I will wait for the child to at least reach a year of age before considering ureteric reimplantation. So at 6 months, it will be either stent insertion or balloon dilatation and stents.
Okay, what if we cannot insert a stent? Is there any other temporary diversion methods?
So a nephrostomy could be considered as a diversion method. If the child is unwell, and then a temporary measure could be the other. So nephrostomy is one, but also a refluxing ureterocystostomy is also an option.
Well done. Yeah. So these are the procedures of choice for babies less than 1 year of age. So below 1 year of age, as you said, temporary double J stenting. If it is not possible, sometimes it is very tight, you might not be able to push the stent through that area. So in which case we can do a cutaneous ureterostomy or a refluxing ureteral reimplantation.
Yeah.
The evidence for endoscopic bile balloon dilatation and endoureterotomy is low, and that is not practiced widely. And after 1 year of age, we can think about the options of ureteric reimplantation. So, what are the options for ureteric reimplantation? I mean, are there any specific methods that's described for obstructive Megaureter?
So generally speaking, ureteric reimplantation can be extravesical or transvesical. The extravesical method is mainly the Leach Gregor. The transvesical methods include the Cohen's trans-trigonal reimplantation or the Leadbetter-Politano reimplantation.
All right, very well done. And what about the ureteric tapering measures?
So in Megaureter, one of the principles is to taper the ureter to achieve the Packing's rule of submucous tunneling.
Okay, so it is 5:1.
1:5, yeah.
Okay, and there are studies says that tailoring of the distal end of the ureter is recommended, and then as you said, it could be either intravesical with a Cohen's cross trigonal or an extravesical. Some of the methods mentioned for the ureteric tailoring of the ureter is either we can fold it like in a star splication, or you can use something called as an excisional tapering. It's called Hendren's.
Okay.
So stars, Kalisinski, and Hendren's are the methods that are used for tapering of the ureter. But
Okay.
in the exam, you have to bring about 2 keywords there. So for ureteric reimplantation of a megaureter, the first is to have the tapering of the ureter following the Packer's rule, and then doing a intravesical or extravesical reimplantation.
Okay.
Well done. And I would highly suggest to read the BAPU consensus guideline on obstructive megaureter. It's an amazing document.
Okay. I'll have